Hello, welcome and kumusta. Thank you for joining me. This is How, your occupational therapist, and welcome to OT Conversations. This time, I'd like us to have a discussion and talk about rehabilitation. That wonderful word called rehabilitation. I find it really very simple and quite easy. And that's me coming from having lots of experience. So obviously, I find it very easy because over the years, I've seen a lot of things when it comes to rehabilitation. And I just would like to have a good discussion with you guys so that maybe we can learn a little something, exchange ideas, or maybe I can stimulate some thoughts in there. Rehabilitation. Okay, let's start. Rehabilitation, it's rehab. Re is doing something. Habilitate is something that was there and you put a person back to where they were. Easy, rehabilitate. And when it comes to rehabilitation, there are a few things that you need to factor in. Number one is time. How much time are you allowed to work with a patient or with your clients? So you can see your rehabilitation approach will vary and will differ depending on the time that you're allowed to work with a patient. Let's look at some examples. If you are in a hospital, for example, and you have a patient who is medically optimized straight away, then your period of rehabilitation is very short. And if the issue is about walking, then you will have to think of getting a person to do the walking safely. And how do you do that? You use a walking frame or a walking stick or an adaptive aid. And this is a compensatory strategy. If, for example, you have enough time to build on the person's balance and you rehabilitate them, then there is more time for you to focus on giving some restorative interventions. Restorative being you get them back to the level where they were. And if you wanted to do the walking, you have to analyze what is the problem with walking. If the problem is endurance and balance, then you need to restore the balance. And then you do some sessions that will improve the balance. And how do you do that? You stimulate the person's protective extensions, protective and writing reactions. You get them to move faster so that their muscles and their arms will quickly respond to losing or being out of the center of gravity. There you go. So that is a restorative sessions. So like I said, time is an important factor when you are doing rehabilitation. Another thing that you need to consider is you look at the problem and then you identify if the problem is something that can be resolved. Because your rehabilitation approach will vary depending on the condition. And you have two approaches. Like I said, you can have the restorative rehabilitation and you can have the compensatory strategy in terms of rehabilitation. And in terms of compensatory rehabilitation, meaning you would use adaptive aids. Restorative rehabilitation means that you resolve the physical problems. And then another part of the compensatory would be providing some kind of support on how a person will engage and will do the things that they needed to do. So two phases of compensatory strategies is either compensatory using adaptive aids or changing the method or a modify intervention technically. And then the other one would have been supportive intervention, whereby you are providing a person with or giving a person with some form of support. Those are the only two things when it comes to rehabilitation. For example, you have somebody who has had a condition that has deconditioned them so much, like say they've been ill for quite some time and they've been in bed for quite some time, particularly in critical care. So say the doctors are happy, good. The next thing that you need to do is you need to think of what do you need to achieve. Say the person is very deconditioned that they cannot get out of bed. So that's the functional side, cannot get out of bed. And if you want the person to be independent getting out of bed, a restorative side, you need to analyze the body. What is stopping this person from getting out of bed? And then you say, oh, generally weak. The upper limb is generally weak. The muscles are generally weak. Then you can do some strengthening activities. If the person is still weak but cannot endure it, then you need to do some endurance activity training. So those are the two things, restore activities. So how do you do endurance retraining? Big movements on the arms, gross motor retraining, done over prolonged period of time. If you wanted to do the strength, then you do give them some exercises, but that is with increasing resistance. Okay, so that would be the restorative side if you want them to get out of bed. The other thing that you need to do is, say, for example, you want them to get out of bed, but it is a situation where it's really difficult to achieve full independence now. The person has become very deconditioned and they're quite elderly. So the chances of physical recovery is quite slow. And then the time factor is against you. What do you need to do? Put a bed lever in. When you put a bed lever, a person will be able to roll properly. And that meant that the person will have a better opportunity to get out of bed with some modified independence. Yeah. So look at the condition, see whether it is something that you can restore within the time frame that you're allowed to work with a patient. For example, if you have hand injury and it is somebody's had a post-operation and you need to maintain that range of movement, and all you need to do is regular passive stretching. You need to facilitate the wound healing on the surgical side of the hand, and you need to extend, for example, the length of the finger flexors. Then you do some splinting, you do some regular stretching, slow and progressive stretchings. So these are some of the things that you can do. What if, for example, the person has a condition that is totally unavoidable and you can't do anything much about it? Like say they've had amputation and then the technique is to get out of bed. Well, that's easy enough to do. You just do the retraining, just practice, get used to doing that. What about getting a person back from the bed to the wheelchair? Then there are some techniques that you can do as well, but you need to strengthen those arms so that the person will be able to do some sliding transfers, or you can do a parallel transfers from bed to chair. There are some wonderful techniques that you can utilize. That is rehabilitation. You can do restorative intervention, and you can do compensatory intervention, and you can do some supportive intervention. Just think of the condition, like say Parkinson's disease. Is this a condition that is likely to improve over time? If not, and if it's going to be deteriorating, then your line of intervention would be part restorative, part modify. And when you do that, you are actually enhancing a person's ability. Then you may be doing a preventative intervention. Modify being using adaptive aids. So if there is a chance for a person to improve, focus on providing restorative treatment. If, for example, the person is slow to improve, you can start by aiming for safety, in which case you can utilize adaptive aids first. Say for walking frame. You can issue a walking frame. And again, this may be controversial for OT issuing walking frames. should be okay. In Canada, people in the States, people are giving out walking frames because these are adaptive aids. But if you look at it in terms of principles, you can give walking frames, but you need to have a service agreement on that one, professional courtesy and professional respect, especially if you're doing some form of interdisciplinary approaches. This is simple. You just do the walking, give them a walking frame. They're not walking at the with proper gait pattern and stuff yet, but they are walking safely with the walking frame. And when it is safer and there's more opportunities for them to do it, then they will be walking more, the more that they will improve. It's quite straightforward, isn't it? It's very easy. Right. So with neuro condition, just think about it. Is this a condition that will last for a long time, or is it acute? What is the severity? What's the nature of the condition? Spinal cord injury, if it is a complete transection of the spinal cord, then maybe you can't do much about it. And if you can't do much about it, then you'll have to compensate and you'll need to use some of the compensatory strategies. So compensatory strategies is something you wanted to do if you cannot fully resolve the problem. So you still need to get the person to doing something. You have to find other means on how to do that. And that would mean you'll have to be reliant on equipment. Just remember, the objective is to get the person back to doing the things that they can, and that means getting the person's body back to the level where it was. And if that is the case, then you need to make sure that restorative intervention is always in the pipeline. Again, factoring in the time and factoring in the location where you're working. If you're a rehabilitation practitioner, whether you're an in-house rehab personnel or you are doing the rehab at home, get the person back to the level where they were physically. So rehabilitation. Now, what are some of the restorative interventions that you can use for neurology, for example? That becomes a little bit more tricky because there will be different components, different factors in terms of restorative sessions and restorative interventions. With cognition, it's either you get it or you don't get it. It's either you have it or you don't have it. Your cognition is either functional or fully functional, or if it's not safe, then you need to have a compensatory strategies. I have yet found a very effective method of compensatory strategies, but they retain the problem-solving abilities. Like myself, for example, I am bad at my memory, so my compensatory strategies involve utilizing memory books. But for other people, when it's bad, it's bad. When memory is so bad that they can't even write down on the memory book, that they forget to do the memory book, that they're working on a rote and routine, then you need the supportive intervention coming from another person. That's cognition. When it comes to perception, again, it ties up with cognition, but you may need to take some time. You do the perceptual retraining to improve on perception, improve on sensation. And when you're talking about sensation, you're talking about visual sensation, tactile sensation, proprioception, auditory sensation. So work on sensation, and understanding the sensation would mean perception, and having a good perception will have the basic cognitive capacities, and then the higher level cognitive function comes in. So those are the sequences of your intervention when it comes to cognitive perceptual retraining. That's why the retraining is called cognitive perceptual retraining or sensory perceptual retraining. Okay, these will be the visual perceptual model or cognitive perceptual model. That's the way on how to address that. If you have issues with sensation, How do you do that? What would be the process and the path for sensation? You get the person to feel. That's what you wanted to do. How will the person feel? Just the sensory receptors has to be there. The nerve has to be there. And then the brain has to be there. So if somebody has a peripheral nerve injury, then sensory receptors may be impaired, or the nerve pathways may be impaired, or if somebody has had a stroke, the brain itself, the command center, and may be impaired. So if those things are impaired, the likelihood of improvement is very, very slim. On which case, you have to be teaching compensatory strategies. But if it's just a condition called neuropraxia or axonotmesis, for example, or neuropraxis, meaning you've just had an impingement, you just need to take some time and the person will regain the sensation again, but you need to give them some form of retraining. So in terms of resensitization, what you need to do is from gross sensation, from rough to smooth sensation. That's the technique that you need to do when you are resensitizing. But if you are desensitizing, it will be from the fine sensory stimulation all the way to the rough texture. So those are the things, that's the pathway for cognition, for sensation. If you want to improve the balance, for example, how do you restore the balance? First, address the static posture of the person. The person needs to be able to assume the position, and then the person will need to be able to shift weight, and then there has to be some functional use. When you're doing the balance, there's a few things you need to factor in. You need to factor in the physical ability of the person, the body. Is the body weak? If it's weak, you need to strengthen it. Is the person slow to respond? So that would be, again, physical stimulation is what you need to do, because the body will be reacting on any vestibular challenges. The other thing with balance is how to restore that. You need to stimulate the vestibular subsystem. And how do you stimulate the vestibular subsystem? You need to go, if they are hyporeactive in terms of their vestibular subsystem, you need to stimulate it. Provide some activities that involves rough activities, angular activities, something that will stimulate their vestibular subsystem. That's from hypo. You need to stimulate it. You need to wake it up. So we'll be talking about the vestibular subsystem. If they are hyper reactive, then you need to start slow and then slowly building up angular movement. So you need to start with some linear activities first. With strength, it's easy. So it's resistance that you are improving. So start the movement first. It's helpful to know the Kendall manual muscle testing, manual grading. Starts with the flicker and then sustained contraction, and then contract, relax, and then contract, and then do it with resistance, and then do it for more and more activities. That's how it would be when it comes to the strength. How else? Endurance. Well, start with building up the activity or doing some things, and you only measure the amount of time the person is engaging. That's how you would restore the endurance. If it's compensatory, then get them to use a wheelchair. If walking is impaired, endurance is impaired, you can't build it up, you need to compensate, you still need to do something, then you cannot restore endurance anymore. You need to compensate, then you need to use wheelchair and or something similar, or a power chair, for example. What else? Range of motion. How do you restore? Just do some passive stretching that you do, and then you put an extra pressure to move it. at least about 5% beyond the end feel, depending on the pain, depending on the end feel, and then just enhance it. So that's one way to compensate for or actually restore the range of motion problem. If it's unavoidable and you can't do much, like for example, somebody's had contractures, then you may have to utilize adaptive aids. They can't reach the backside because there's contracture on an elbow, for example, then you just have to use some back scratchers. Now, with these compensatory strategies, normally occupational therapists are on the ball with this. This is normally our place to do things. Physios are more restorative in nature. So it's kind of frustrating sometimes when you're working with physiotherapists and their first line of action would be compensatory strategies. Equally, because OTs are using a lot of compensatory strategies, sometimes the restorative component and the restorative treatment is no longer a part of the arsenal of treatment interventions that OT does. So it is quite sad. What else? What other components out there? Or what about laterality? It's more perceptual, just use it. Okay, you can use behavioral approach on that one. So it's not a huge problem when it comes to laterality. Laterality would be the handedness. If, for example, a person is right-handed and there was an injury on the right hand, question is it something that will resolve itself? If not, then wait for the impairment to resolve so you can use the right hand again. If it is difficult, then you'll have to compensate by teaching the person to use the left side. What else? Crossing the midline, that's another component. It is, again, easy. You just have to do it. But when you're doing some crossing the midline activities, it is much more facilitatory if it is a big movement, crossing the midline, rather than just a paper and pen or tabletop activities. Do something that will involve multi-sensory stimulation that involves trunk rotation. Okay, that's crossing the midline. Body scheme. This, you will find this in problems when it comes to use of like dressing and showering. Then just do functional activities. Enabling activities will involve, again, crossing the midline, something that gives stimulus to the body, so person will attend to the body and then will be moving. So all the challenges, so the more input that the body will get, the better the person will understand their body. So you don't just teach them body parts because that's cognitive approach. But in fact, a body scheme will become a problem because there's been an impairment on either the neural pathway or on the end stage, which would have been the brain. Right. Lots of intervention, guys. This is what I'm talking about when it comes to the treatment of rehabilitation. It's not all about compensation. It is also about restoration. And when you have to restore some activities, you need to know how to grade it. You need to know how to evaluate it. And you need to design an activity that will provide that kind of quality of stimulus or challenge to the person. Enjoy and have fun. Until next time, bye.
If you enjoyed this podcast, talk to your friends and colleagues about it. Like it, subscribe, share, and do what you can to appease whatever algorithm that is at play. Just remember, guys, anything you do matters and has an outcome. Until next time, bye.